بسم الله الرحمن الرحيم. دكتور معاذ معانا؟
اي نعم معكم، يعطيك العافية. الصوت واضح؟
معاذ.
السلام عليكم.
وعليكم السلام.
الصوت واضح؟ اي نعم، يعطيك العافية.
واضح.
اي نعم، جزاكم الله خير. شكرا لكم.
اوكي. الدكتورة وسام جاهزة؟
جاهزة. السلام عليكم.
وعليكم السلام. بسم الله الرحمن الرحيم. Good evening everyone and welcome to today's sessions in the Pediatric Critical Care chapter under the Saudi Critical Care Society. I would like to welcome all you and to introduce our today's speaker. We have Dr. Wesam Al-Thaqafi. Dr. Wesam, she is a consultant general pediatrics and palliative care at King Abdullah Specialized Children Hospital. She is a holder of Saudi and Arab Pediatric Board. She did her training in King Fahd Medical City, and then she moved to Sick Kids at Toronto, where she did her fellowship in palliative care. She's a holder as well in bioethics master. Dr. Wesam, she's actually an active member in education and research, and she has a very successful work in developing the concept of pediatric palliative care at King Abdullah Specialized Children Hospital. And we hope this concept will be spreading all through the kingdom. Please welcome with me Dr. Wesam Al-Thaqafi. She will talk to us today about demystifying the palliative care at pediatrics. And I'm sure that you will enjoy her talk. Thank you.
Assalamu alaikum. Ya'tikum al-afiyah. Thank you very much for inviting me for the second time in your respected forum. In our previous meeting 2 or 3 years back, we talked about the principle of pediatric palliative care and general overview. And today probably we will dig more about in some of the major myths that preventing the successful implementation of palliative care in our country or region. I have no conflicts of interest. Just maybe I used a word that need to be further elaborated, which is demystification, or this demystifying means is removing myth or suspense about a specific subject. Let's talk about just another overview or refresh background about the palliative care, which is an emerging medical subspecialty initially recognized by American Academy of Pediatrics in 2006. And according to international children palliative care work, there are around 20 million children would benefit from pediatric palliative care annually, and there are around 8 million children would need specialized palliative care. Palliative care is about matching treatment to patient goals and is considered specialized medical care for children with serious illness. It focuses on relieving pain, distressing symptoms, and stress of a serious illness, and it's appropriate at any age, at any stage of illness, and together with the curative treatment. The primary goal is to improve quality of life for the child and his or her family. Palliative care is no longer means helping children die well. It means helping children and their families to live well, and when the time is certain, to help them die in a dignity. The objective of my talk today is to address and critically evaluate some common assumptions, myths, and barriers which may hinder the implementation of pediatric palliative care into the care of children with advanced diseases. I will talk in my speech today about around 9 common myths, but there are plenty of them. I choose the most ones. Let's go with the first one. Pediatric palliative care is usually for children with cancer. Palliative care is strongly connected with cancer patients, but it's not actually the case. In this study, the majority of children living and dying of a life-limiting disease do not have malignancy. Out of 1.7 million deaths that occurred from age 0 to 24, found only 5% were attributed to cancer, and the majority are for non-cancer causes. Another study or registry of a total of 42,000 children die yearly in the United States, only 4.3% were attributed to cancer or malignancy. Another another study in North American cancer only comprises only 30 to 40% of children seen by pediatric palliative care. So after all those numbers, we can say myth busted. The second assumption is about involving of pediatric palliative care team means doing nothing and children live shorter. Pediatric palliative care clinician would never say there is nothing else we can do. In fact, there is always a lot we can do. Even when the underlying condition cannot be cured, sophisticated medical technology will be used to control their symptoms and to improve their quality of life. And palliative care translates the advanced pain and symptom management and providing best quality of life, and therefore a very active advanced approach to symptom management and family support. So we cannot say that nothing can be done. Actually, it's a very active approach. A groundbreaking randomized control trial in an adult setting actually showed that involvement palliative care increased the quality of life, decreased depression, and led actually to prolonged life with an age from 11 months, from 8 months to 9 months, with a significant p-value. Another study showed around the similar result that early involvement of palliative care significantly, lengthened the survival rate by 1 year rather than shortening life. In pediatric setting, in this mentioned study published in Pediatric in 2015, parents of children with cancer who received pediatric palliative care reported less distress from pain, dyspnea, and anxiety. And children who receive pediatric palliative care, 70% have fun compared to 45% without pediatric palliative care. 89% of those families reported improved communication. Children receiving palliative care experience shorter hospitalization and fewer emergency department visits and less ICU admissions. So again, we can say myth busted. The third assumption that pediatric palliative care starts only when curative treatment stops. What is the rationale behind that of those assumptors? Pediatric palliative care erroneously be considered only when curative treatment stops and when the child is close to death. The other assumption that children shouldn't die. We have to support them the most, so they shouldn't die. The need to ensure that everything possible, it will help the family to cope with the death of their children. So we need to offer everything so they can cope better. Those are the rationale behind this assumption. But actually, earlier recognition by both physicians and parents that the child had no realistic chance of cure strongly emphasized on treatment to lessen suffering and integrate pediatric palliative care. Palliative care, therefore, is the best to be started at the time of diagnosing of life-threatening disease. It should continue through the trajectory of illness, and it does not equal to end-of-life care, but certainly it includes it. Pediatric palliative care extend even beyond the death, and our relationship with the family shouldn't end by the end of life. It should continue after death, which is bereavement service. So myth busted. Our fourth assumption is parents have to choose between fighting for a cure or give up hope, and it's not the case. It's not either or, it can be both curative or disease-directed approach plus palliative care. It's not a choice either or. A child doesn't have to continue to continue in disease-directed therapy in order to perceive hope. In fact, large adult study could demonstrate that chemotherapy is actually not prolonging life, and in addition, it reduces the quality of life. And regardless decision regarding continued disease-directed therapy need to be carefully considered, weighing potential for life extension and impact on quality of life. So it's not only about prolonging life. Certainly caring for dying children is emotionally very difficult, and referral to palliative care is considered as giving up hope. And this is causing an emotional cost of recognizing the child who are dying, and this will delay planning the optimal care and support. Hope of cure and pediatric palliative care include each other and not contradicting each other. So it doesn't mean if you refer to pediatric palliative care, that means you are taking off hope. Pediatric palliative care is actually translate into advanced management to maintain or improve quality of life and children, or can be graduated from palliative care, not necessarily to continue for life with palliative care. If their distressing symptoms or disease does not require palliative care support, they can be discharged from palliative care. So despite the prevailing myth, to the contrary, that means that palliative care is shortening life, life-saving care, and excellent symptoms relief can usually be simultaneously, not overriding one another. Palliative care explicitly doesn't mean giving up hope. It might be a different way of hope. Look at this scenario, for example. It's not necessarily the hope is only cure. For example, palliative care specialist might ask the parents, tell me, considering what your child is up against, what are you hoping for? The family, for sure, they might say cure from the disease or a miracle. The palliative care might respond, I hope this too. I am with you just in case the disease cannot be cured. What else are you hoping for? You will be surprised. Their hope might be modified to simple things that can be matched. By tracing the hope further, families may wish for example, aggressive or advanced pain and symptom management. They might ask to go outside or home. They might ask to meet a family member or make a wish or anything else. So even when underlying condition cannot be cured, palliative care will not give up hope. So myth busted. The fifth assumption is that pediatric palliative care should only be occur in children hospital. We are, or actually the practitioner or we are assuming that end of life is preferred to be in the hospital as it's a secured environment. But in a study done in a well-known hospital, which is Great Ormond Street, they found that prior establishing palliative care, the wish to be the death will be at home was only 19% and increased up to 77% after establishing palliative care. In another study showed direct correlation between preference of parents or child receiving palliative care to stay at home toward end of life. As we mentioned in the previous slide, 70% likely to have more fun, 89% experience events that add meaning to life, and 93% versus 20% wish to die at home if they feel that they are supported or secured. So myth busted. The sixth assumption is increasing the dose of opioid causes respiratory depression, and this is a very, very common assumption and fear from opioid and morphine and etc. And that's it enhances or quickens death. Opioid will hasten death and should only be administered as a last resource. This is the assumption. But in a study published in Lancet 2000, this year was contradicted in the adult literature, commonly observed that administering opioid and benzodiazepine together with the comfort care to relieve dyspnea and pain not only improve the quality of life, but also prolongs life. Retrospective cohort study of 223 adults oncologist patients reviewing the mean survival in relation to opioid use from less than twofold increase in their initial opioid dose resulted in 9 days survival, more than twofold increase in 22 days survival. So actually, if you are relieving their distressing symptoms, you might actually prolong life rather than shortening it. So morphine kills the pain, not the patient. So myth busted. The assumption number 7, pediatric palliative care, takes patients away from primary pediatric specialists. And also this is another cause of discomfort in referring patient to palliative care, thinking that palliative care will inherit the patient from their primary services. The interdisciplinary pediatric palliative team is complementary service and actually it's only an extra layer of support. The pediatric palliative care philosophy at most program will strongly support maintain the primary relationship between the child, family, and clinical team. Actually, we don't recommend transferring the whole care to palliative care toward the end of life, and we also support maintaining the relationship with the primary team rather than inheriting the patient. Think of palliative as if you are consulting ID service, for example. Every one of us, I'm sure, knows how to prescribe antibiotics, but you consult infectious disease specialist if you struggle with antibiotic choice, combination, or for further expertise. Think of palliative care the same. Primary, but there are levels for providing palliative care. There are primary palliative care and there is subspecialty palliative care. Primary palliative care is provided by primary pediatric team and integrates palliative care approach into daily pediatric medicine. I'm sure you are expert in this as intensivist. Subspecialty palliative care provide designated interdisciplinary palliative care team with skills in advanced pain and symptom management, education, research, advances in the field. So myth busted. We are not inheriting the patient. Assumption number 8, pediatric palliative care teams are expensive and therefore healthcare systems cannot afford them. And also this is one of the major barriers in this, from the stakeholders not to support palliative care, thinking that the patient will stay in the hospital longer, will consume more resources. Pediatric palliative care is now an expected standard of practice in every children's hospital. And it's in every single one of the US owner children's hospital, each one of them has or should have a palliative care team to earn this prize. And palliative care involvement result in better outcome, lower cost. Palliative care program reduces stress, cost of care for children with life-threatening condition. Retrospective study of around 500 children in palliative care, home care in US, comparing to pediatric hospital resource utilization, found that length of hospital stay reduced by 38 days and decreased the hospital charge by around 300,000 per patient. before palliative care and after palliative care involvement. Regardless is the cost of palliative care, it is much cheaper than cure-directed approach and full support. Here are some of the numbers comparing before involving palliative care and after, comparing life discharge and hospital discharge. And you can see they are less in cost, in total cost per day, direct per admission, lab, ICU, pharmacy, imaging, and it's also statistically significant. This is another slide, can give you an idea. You can see the yellow is before involvement palliative care and the red is after. So the hospital stay got less, around 40 days, and the hospital expenses by half, probably reduced by half. So myth busted. Palliative care is not more expensive than a disease treat approach. I think maybe you might be interested in this specific assumption, being an intensivist. Intensivists know everything about end of life and symptom management, thus we don't need to consult pediatric palliative care. And actually in this mentioned study, incidence of poor communication within an ICU admission is as high as 70% and highly predictive of conflict. Despite reported confidence, providers demonstrate poor symptom management and under recognition of dyspnea, nausea, secretion, agitation, psychological symptoms. As many as 60% of bereaved parents reported poor management and toward end of life, including pain. And last but not least, PICU poorly anticipate complicated grief phenomena occurring in up to 60% of bereaved ICU parents. So it's not only about we know the best in giving opioid, for example, or we know the best in conducting breaking bad news sessions or communication sessions. Families reported the stress caused by uncaring delivery of bad news and careless remarks made by staff members. Family reported also, and they are like observing their children suffering without an intervention. And this was published in a well-known journal, as you can see. A survey of a pediatric intensivist revealed high level of confidence in their ability to treat pain and acute symptoms, but despite this confidence, pain and other symptoms such as dyspnea, nausea, constipation were under-recognized and under-treated. ICU has a basic or primary palliative care approach. However, for complex decision-making, complicated grief, care transition, high symptom burden, intensivists might seek the palliative care expertise. So I think myth busted. I want to take this chance because I have event happened with me yesterday, and today, for one of the patients I have been always consulted about. She has a very bad encephalitis and with intractable agitation and pain. She is requiring high doses of opioid and benzo and others to settle her down. But unfortunately, every time she was admitted to ICU for sepsis or for anything, the first reaction from our colleague in ICU is to wean her sedation. And when I discuss it frankly with one of my colleagues why this happened, they clearly mentioned because she is not no code or because she is not palliative patient, she shouldn't be on chronic morphine therapy. And that was really actually traumatized me because this is not the case. She needs help to control her symptoms. She doesn't need to be no code or DNR to relieve her pain. I cannot correct or cure her primary disease. She really needs aggressive pain management. So regardless of whether it generate a lot of revenue, it's just mission critical. Families need it. Critically ill children need it. Children with chronic disease needs it. Children with complex medical problem needs it. They all need pediatric palliative care. It's absolutely essential to their recovery, to their health, and some case to death with dignity. It's one of those gotta do things. It's not optional, it's mandatory. If you want to care for children in quality way today, pediatric palliative care has to be part of this standard practice. It's not a choice. So final words, palliative care is not a luxury, it's a necessity. It's based on the needs, not the prognosis. Palliative care adds life to days, not days to life. It's always right for any patient with life-threatening, life-limiting illnesses, regardless the diagnosis. It's for any prognosis, it's for any age, it's for any stage of illness. It can be provided anywhere, home, hospital, hospice, and any care provider can provide some sort of palliation, except for limited cases. I will end with this preferred slide to me. Delivering pediatric palliative care goes to stages. So initially it's from denial, then to palliphobia, which is like severe fear to talk about palliative care or refer patient to palliative care, and to the stage of pallilalia, which everyone, I think we are in this stage, everyone is nowadays talking about pediatric palliative care, and we need to move it to palliactive and inshallah to palliative at the end. So it will be an essential care for each pediatrician. And thank you very much.
Thank you, Dr. Al-Thaqafi, for this very informative and very nice talk.